Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Absolutely.
And to kick off this deep dive, I want you to put yourself right in the trauma bay.
Oh, yeah, we've all been there.
Right. It's 2 a.m. You've got a patient who just rolled in from a motor vehicle collision, just a high-speed fender bender, or maybe, a sudden deceleration where the seatbelt locked up hard.
Yeah, that classic mechanism.
Exactly. And they are talking to you. Their Glasgow Coma Scale is a pristine 15.
Perfect.
The primary survey is completely clear. Hemodynamics are, well, they're perfectly stable.
So you're thinking, okay, this is a straightforward one.
Right. They feel fine. Maybe they're complaining of just a little stiffness in the neck, which, you'd expect after a crash like that.
Sure, standard whiplash protocol.
Yeah, so you're ready to clear them, maybe send them up to the floor for a standard observation period.
But there's a catch.
A huge catch. Because what you can't see on that primary survey, and what the patient absolutely cannot feel, is that a hidden physiological clock has just started ticking.
And it is a very fast clock.
It really is. Today, we are immersing ourselves in the high-stakes, highly nuanced world of blunt cerebrovascular injuries, or BCVIs.
And for those of you managing these polytraumas on the front lines, you know exactly how deceptive this mechanism of injury can be.
Oh, absolutely.
We are looking at a foundational textbook excerpt by Berlew, Maizoso, and Moore on the screening, grading, and management of these specific vascular traumas.
It's a fantastic text.
It really is. We're going to break down the evolution of the standard of care, how a massive paradigm shift in trauma screening took an injury that once carried a devastating 24% mortality rate and engineered it down to less than 5%.
Which is just a staggering drop, statistically.
It's incredible.
But to really grasp the gravity of that drop, I think we have to look at the raw mechanics of the injury first.
Right, the biomechanics.
Because we aren't talking about penetrating trauma here.
No knife, no bullet.
Right. The neck looks completely intact from the outside. So what is physically yielding inside the cervical anatomy when a human body decelerates from 60 miles per hour to zero in, a fraction of a second?
Well, it really comes down to the architecture of the cervical vasculature.
Okay.
And its intimate, highly unforgiving relationship with the bony structures of the spine and the skull.
Unforgiving is the right word.
Yeah, because we are primarily concerned with 4 vessels here. You've got the bilateral internal carotid arteries anteriorly and the bilateral vertebral arteries posteriorly.
Right.
The inherent vulnerability lies in their anatomical pathways.
How so?
Well, the carotids, they ascend through the relatively forgiving soft tissue of the neck, but as they reach the skull base, they enter the rigid petrous portion of the temporal bone.
Right. They basically hit a bone wall.
Exactly.
Yeah.
And the vertebral arteries are even more confined. From C6 up to C1, they are literally threaded through the transverse foramina.
Which are, for our listeners, bony tunnels within the cervical vertebrae themselves.
Yes, surrounded by hard, jagged bone, leaving zero room for displacement.
Zero room. And Chrissy and Bernstein originally laid out 3 fundamental mechanisms that result in a BCVI.
Right, the classic 3.
The first one is a direct blow.
Yeah.
Which we see frequently with improperly positioned seatbelts leaving that distinct abrasion across the neck. Or a direct crush injury in contact sports.
Sure.
But it's the second mechanism that we see constantly in motor vehicle collisions, specifically driving carotid artery injuries.
Hyperextension with contralateral rotation?
Yes. The body is restrained, but the head whips backward and twists violently to the side.
And when you visualize that biomechanical vector, you can see exactly why the anatomy is the enemy here.
Right.
During that hyperextension and rotation, the internal carotid artery is violently stretched over the lateral articular processes of the upper cervical vertebrae.
Specifically C1 through C3, right.
Exactly. The vessel is essentially pulled taut over a bony fulcrum. And with the vertebral arteries, you have the exact same problem. Because they are tethered within those transverse foramina, when the cervical spine hyperextends or subluxates, the bone moves.
But the vessel doesn't.
Right, the vessel is anchored. So the sheer stress applied to the vessel wall is just immense.
It's massive.
Yeah.
And then you have the third mechanism, which is direct bone fracture injury.
Which is brutal.
Yeah, if a patient sustains a basilar skull fracture, particularly through the sphenoid or petrous bones, or if they fracture a cervical vertebra, the sharp fractured edges of that bone directly lacerate, compress, or shear the adjacent vessel.
Right, the bone literally cuts the artery.
But I want to push past the macroscopic trauma for a second and look at the microscopic reality.
Okay, let's zoom in.
Imagine a high-pressure, reinforced industrial hose.
Great analogy.
If you grab it by both ends and stretch it violently, the thick outer rubber, which is the adventitia of our artery, might look perfectly intact.
Right. From the outside, it looks fine.
But the inner lining, the intima, cracks and frays under the tension.
And taking that analogy further, the danger isn't just that the inner lining is frayed.
No.
The danger is what happens when the high-velocity fluid rushing through that hose interacts with the frayed lining.
The blood.
Exactly. When the intima layer of the artery tears, it immediately exposes the highly thrombogenic subendothelial collagen layer to the bloodstream.
And to the human body, exposed collagen is, well, it's the ultimate blaring alarm bell.
Oh yeah, it's the trigger for the entire coagulation cascade.
Right.
The von Willebrand factor in the blood binds instantly to the exposed collagen, which in turn acts as a massive anchor for circulating platelets via their glycoprotein IB receptors.
Okay.
The platelets activate, they release thromboxane A2 and ADP, and you get this aggressive cross-linking via glycoprotein IBI receptors.
Wow, so the body just goes into overdrive.
Totally. The body rapidly builds a thrombus right over the tear.
Yeah.
Evolutionary biology is doing exactly what it's supposed to do, right? Plugging a hole to prevent exsanguination.
But the body is blind to the context here.
Yeah.
It doesn't realize it's building a plug inside a critical, high-flow artery supplying the brain.
No, it just sees a leak.
Right, and from a clinical standpoint, that thrombus is a ticking time bomb.
It really is.
It can proliferate until it causes severe luminal narrowing or complete acute occlusion.
Starving the downstream brain tissue of oxygen.
Exactly.
Oh.
Or, perhaps even worse, pieces of that highly unstable fresh clot can shear off under the arterial pressure.
Embolization.
Yeah. You get an embolus that shoots directly into the cerebral circulation, lodging in the middle cerebral artery, triggering a massive ischemic stroke.
And we also have to account for the structural integrity of the vessel wall itself following that stretch.
Right, it's not just the clot.
No, that intimal tear can act like a one-way valve. High-pressure arterial blood forces its way under the intimal flap, dissecting the layers of the artery apart.
Which is terrifying.
Yeah, it creates a false lumen that expands and physically compresses the true lumen.
Okay.
Or the entire weakened wall can balloon outward, creating a pseudoaneurysm.
And those are bad news.
Extremely. These pseudoaneurysms create turbulent, swirling blood flow within their sacs, which is a perfect nidus for even more thrombus formation.
Not to mention the risk of eventual catastrophic rupture.
Exactly.
And yet, returning to that patient sitting in the trauma bay, they don't feel any of this happening.
Nothing.
The external neck is fine. There is no expanding hematoma. They might just have a headache or neck pain that you'd easily attribute to standard whiplash.
You wouldn't think twice.
Which brings us to a really terrifying clinical reality, the silent period.
The historical context of this silent period is fascinating, actually.
Oh, yeah.
Yeah, these injuries were first documented back in 1872 by the French surgeon Verneuil.
Wow, that long ago.
Right. But for over a century, the medical community considered them exceedingly rare zebras.
Why is that?
Well, because by the time the patient actually stroked out days, weeks, or even months later, the initial blunt trauma was either entirely forgotten, or the neurological collapse was simply written off as a delayed consequence of the primary traumatic brain injury.
Ah, so it was misattributed.
Completely.
Let's talk about the timeline of that silence. The literature states that the vast majority of these ischemic events occur between 12 and 75 hours post-injury.
Right.
The peak incidence of a stroke hitting is sharply defined right between hours 13 and 24.
That's the danger zone.
So I have to ask, if the biomechanical stretch, the actual tearing of the intima happens at 2 p.m. on Tuesday, why does the middle cerebral artery stroke hit at 2 a.m. on Wednesday?
It's a great question.
What exactly is the biology doing for those 12 to 24 hours?
It's basically an issue of hemodynamics versus coagulation kinetics.
Okay.
When that microscopic tear happens, the platelets start aggregating immediately, as we said.
Right.
But the internal carotid artery is a high-flow, high-velocity system.
Yeah, a lot of pressure there.
Exactly. So the sheer stress of the blood rushing past the tear is constantly tearing away the early fragile platelet plugs.
Oh, I see.
Yeah, it is a slow, iterative battle between the body trying to build a stable fibrin mesh and the arterial flow just washing it away.
Fascinating.
It takes hours for that thrombus to achieve enough architectural integrity and critical mass to either occlude the vessel entirely or to grow large enough that a clinically significant massive embolus breaks off.
So that 12 to 24-hour delay is literally just the time it takes for the biological concrete to set.
That is exactly it. And the profound clinical takeaway is that this delay is the one gift the trauma surgeon gets.
The window of opportunity.
Yes, it is the exact finite window of opportunity to intervene, stabilize the endothelium biochemically, and save the patient's brain, provided, to look for it.
But even if we understand the timing, we really have to look at the collateral damage when the stroke does hit.
Right.
And why some patients survive a complete carotid occlusion while others suffer a devastating hemispheric infarction.
It's a massive variance.
It is. And we can't talk about cerebrovascular trauma without talking about the circle of Willis.
The famous traffic circle.
Exactly. The circle of Willis is the anastomotic ring of arteries at the base of the brain.
Right.
In a perfectly designed human, it acts as a failsafe. If your right internal carotid artery occludes from a blunt thrombus, the circle of Willis should, in theory, shunt blood over from the left carotid and up from the basilar system, maintaining perfusion to the right hemisphere.
In theory.
In theory. But the data from the text highlights a staggering anatomical vulnerability. The circle of Willis is incomplete in roughly 80% of the population.
80%? It's wild.
80%.
It is a massive embryological oversight, honestly.
Seriously.
Most people have hypoplastic or completely absent anterior or posterior communicating arteries.
Right.
This means they completely lack a functional collateral backup system.
Okay, so what happens then?
Well, if a trauma patient with an incomplete circle occludes a carotid, or if an embolus lodges above the circle in the middle cerebral artery, that entire vascular territory is going to undergo infarction.
The tissue will die.
Period.
And when that ischemia hits, the clinical presentation diverges wildly, depending on which anatomical system took the hit.
It's very different.
Yeah. With carotid artery injuries, the symptoms are what we typically associate with a classic stroke, a contralateral sensorimotor deficit.
Right, hemiparesis.
Exactly. If the right carotid throws the clot, the left side of the body experiences hemiparesis or paralysis.
And speech issues, too.
Yeah, if the injury affects the dominant hemisphere, you see profound aphasia. If it's the non-dominant hemisphere, you might see hemineglect.
But vertebral artery injuries present a much more insidious diagnostic challenge.
How so?
Well, the vertebrals supply the posterior circulation.
Right, the back of the brain.
Yeah, the brainstem, the cerebellum, the occipital lobes. So the symptoms of vertebrovascular ischemia are often vague and incredibly easy to dismiss in a loud, chaotic trauma bay.
Like what?
We are talking about ataxia, dizziness, vomiting, visual field defects, or facial analgesia.
I want to push back on that from a practical standpoint, though. If you are evaluating a polytrauma patient who just rolled their SUV and they are dizzy and vomiting,
Right.
99 times out of 100, the team is going to attribute that to a concussion, a mild TBI, or even just a side effect of the fentanyl pushed in the ambulance.
Exactly.
Nobody's first thought is, oh, this patient is having a posterior circulation stroke.
And you're highlighting the exact cognitive bias that kept the mortality rate at 24% for decades.
Wow.
If you wait for the classic stroke symptoms to manifest, or if you write off dizziness as a concussion, you have already lost the game.
The clock ran out.
The silent period has expired, the infarction has occurred, and the neurological deficit is likely permanent.
That's grim.
Now, yes, there are hard signs that demand immediate operative or angiographic exploration.
Right, the obvious stuff.
Yeah, active arterial hemorrhage from the mouth or ears, an expanding cervical hematoma, a cervical bruit in a young patient, or an obvious focal neurological deficit.
But those are reactive.
Exactly. Relying on hard signs is a reactive strategy. The modern standard of care requires a proactive strategy.
Which means we can't wait for symptoms. We have to hunt for the injury while the patient is still perfectly asymptomatic.
Exactly.
And that requires a monumental shift in how trauma systems operate, moving away from symptom-based diagnosis to mechanism-based screening.
It was a massive culture change.
Let's talk about the old days. Historically, BCVI was considered a medical unicorn.
A total myth to most.
Right. It was thought to occur in less than 0.1% of all blunt trauma admissions. Blunt injuries accounted for less than 3% of all traumatic carotid injuries. The vast majority were penetrating trauma like gunshot wounds.
But it wasn't a unicorn. The medical community simply had its eyes closed.
Wow.
Yeah, in the first major multi-center review conducted by the Western Trauma Association, they found only 49 patients with carotid injuries across 11 major level 1 trauma centers over a 6-year period.
That's nothing.
It's artificially low because nobody was looking. But once aggressive, asymptomatic screening protocols were initiated, the authors of this chapter describe the result as a veritable epidemic of BCVIs.
The numbers exploded. From 0.1%, the incidence jumped to between 1% and 3% of all blunt trauma admissions.
Yeah.
And if you look at high-risk populations at centers utilizing comprehensive screening protocols, the yield is up to 34%.
Which is just terrifying.
1 in 3 high-risk patients has a torn artery in their neck. But that stat alone creates a massive logistical problem.
Oh, resource-wise, yeah.
You can't just throw every single person who rear-ends someone at a stoplight into a CT scanner.
No, you'd bankrupt the hospital.
Right. The resource allocation would bankrupt the hospital, and the radiation exposure to the general public would be indefensible.
Exactly. You need highly specific, evidence-based criteria to identify that high-risk cohort.
And this is where the Denver screening criteria comes in.
It fundamentally changed the landscape of trauma surgery. The Denver group identified that specific high-energy transfer mechanisms and the resulting specific anatomical fractures were highly predictive of vascular stretch and tear.
Let's break down the biomechanical logic of these criteria, because it's not just a random list of injuries.
No, it's very deliberate.
If a patient comes in with displaced mid-face fractures, like Lefort second or third, why does that trigger a neck scan?
Think about the force required to detach the maxilla from the skull base, which is basically what a Lefort 3 fracture is.
Right.
That massive anterior to posterior energy vector doesn't just stop at the facial bones.
It keeps traveling.
Exactly. It propagates through the basilar skull, right where the internal carotid artery is anchored in the petrous canal.
Ah, I see.
The same principle applies to complex basilar skull fractures, occipital condyle fractures, or severe mandible fractures.
That's about the kinetic energy.
Exactly. The sheer kinetic energy required to shatter those dense bones almost guarantees that the adjacent tethered vasculature was subjected to extreme violent distraction.
That makes perfect sense. The criteria also include a severe traumatic brain injury with a GCS of less than 6.
Right.
Cervical spine fractures, subluxation, or any ligamentous injury at any level.
Yep.
Near hanging with a noxic brain injury.
Yep.
And the classic clothesline injury, or seatbelt abrasion, coupled with significant swelling, pain, or altered mental status.
And as the data matured, the trauma community realized that early iterations of these protocols were still missing about 20% of true BCVIs.
20% is still too high.
Way too high. So they expanded the criteria.
Okay.
They added complex injury patterns like a traumatic brain injury combined with a thoracic injury.
Oh, interesting.
Scalp degloving, which indicates massive shear force, thoracic vascular injuries, upper rib fractures, and blunt cardiac rupture.
So the neck got wider.
Yeah, the underlying philosophy shifted. If the body absorbed enough force to rupture the heart or deglove the scalp, the cervical vessels were undoubtedly subjected to extreme tension.
So knowing who to scan is the triage victory. But the technological victory is what kind of camera we use to look inside the neck.
The imaging evolution is a great story.
Historically, the absolute gold standard was 4-vessel digital subtraction arteriography, or DSA.
Right, DSA. It's a highly invasive, catheter-based angiogram.
Walk us through that.
Well, an interventional radiologist punctures the femoral artery in the groin. They thread a catheter all the way up into the aortic arch, selectively intubate the carotids and vertebrals, and inject a high-density iodinated contrast dye while taking rapid sequence X-rays.
Okay.
It subtracts the bone from the image, leaving a beautiful, dynamic, high-resolution map of the vascular lumen.
But practically speaking, for a busy trauma center receiving multiple level 1 activations a night, using DSA as a universal screening tool is a logistical nightmare.
It's impossible.
Right. It's incredibly labor-intensive. It requires mobilizing an angiography suite and an interventional team, taking them away from therapeutic interventions.
Yeah, you tie up the whole suite.
And if a rural or community hospital doesn't have those resources, the patient has to be emergently flown to a larger center just for a screen.
And beyond the logistics, DSA carries significant iatrogenic risks.
Yeah, let's talk about the risks.
You are threading a rigid catheter through the exact vessels you suspect might be freshly torn.
That sounds dangerous.
It is. The catheter tip itself can mechanically worsen an intimal flap, dislodge a friable thrombus, or cause an iatrogenic dissection.
Wow.
You have a real non-zero risk of causing the exact stroke you were trying to prevent.
So the trauma community desperately needed a non-invasive, rapid alternative.
Enter CTA.
Right? Computed tomographic angiography.
Yeah.
It takes minutes, it's entirely non-invasive, and honestly, the polytrauma patient is already going to the scanner for a pan scan of their head, C-spine, chest, abdomen, and pelvis anyway.
Exactly. It's just one fluid protocol.
But the transition from DSA to CTA wasn't smooth. In fact, early on, it looked like a failure.
Yeah, the early application of CTA was heavily constrained by the technology of the late 90s and early 2000s.
The resolution was pretty bad, right?
We were using 1 to 4 slice CT scanners. The spatial resolution simply wasn't there. Studies showed these early scanners had dismal sensitivities for diagnosing BCVI, hovering between 47% and 68%.
That's basically a coin flip.
Right. In trauma surgery, a screening test that misses half of the fatal injuries is functionally useless. You cannot safely rule out a ticking time bomb with a 50% false negative rate.
But Moore's law applies to medical imaging, too. The hardware evolved rapidly to 16-slice CTA.
And here is where the literature provides a fascinating lesson in both technology and human perception.
Oh, this was my favorite part of the chapter.
Yeah, Eastman and his colleagues published a study evaluating 162 patients, comparing the new 16-slice CTA directly against the gold standard DSA.
And the results?
Spectacular. They reported a 100% sensitivity for detecting carotid artery injuries and 96% for vertebral artery injuries.
It was a huge jump.
Out of 162 patients, they only had 1 false negative, and it was a clinically insignificant low-grade injury.
But you have to contrast the Eastman data with the contemporaneous studies coming out of Harborview and the Medical College of Virginia.
Right. Those are crucial.
These studies are absolutely vital for understanding that medicine is not just about the machine. It is about the human interpreting the data.
Absolutely.
The Harborview group took 82 patients who had a normal negative screening CTA and, per their protocol, subjected them to the gold standard DSA anyway.
And what did they find?
The DSA found 7 distinct BCVIs that the CTA had supposedly missed. That gave the CTA a negative predictive value of only 92%.
Now, I have to stop right there.
Yeah.
If I'm a trauma director reading that paper in the early 2000s, I'm abandoning CTA immediately. A negative predictive value of 92% means nearly 1 in 10 patients I clear might go home and have a massive stroke.
Okay.
That's unacceptable.
And that was the initial reaction.
All right.
But the Harborview researchers did something brilliant.
Okay.
They didn't just throw the scanners out. They went back and performed a blinded retrospective review of those 7 normal CTA scans.
To see what went wrong.
Exactly. And what they found completely flipped the narrative. The machine hadn't failed. The injuries were clearly visible on the multiplanar reformats in 6 of those 7 patients.
The hardware captured the tear perfectly.
Right. So the radiologist failed.
Well, it wasn't a failure of competence. It was a failure of experience.
What do you mean?
The human eye had not yet evolved to recognize the subtle radiographic signatures of microscopic intimal tears.
They didn't know what to look for.
Right. Radiologists were trained to look for massive intraparenchymal hemorrhages or large subarachnoid bleeds. They were not accustomed to hunting for a 2-millimeter lucency in the internal carotid artery right at the skull base.
Which is a tough area to scan anyway.
Notoriously plagued by beam-hardening artifacts from the dense petrous bone.
That makes perfect sense. The skull base is a radiographic nightmare of bone streaks and shadows. Finding a tiny vessel flap in there requires a massive cognitive adjustment.
And the data proved that adjustment happened.
How so?
The researchers noted that all the missed injuries occurred in the first half of the study period. By the second half, the radiologists had calibrated their eyes.
Wow.
The Medical College of Virginia group reported the exact same phenomenon. Initially, they had a massive 43% false positive rate radiologists overcalling every streak artifact as a tear out of an abundance of caution and a 9% false negative rate.
Right.
But again, all the missed injuries were clustered in the early phase of the study. Once the radiologists climbed the learning curve, the sensitivity and negative predictive value of the 16-slice CTA hit 100%.
We've now moved well beyond 16 slice into 64 slice and whole body multi-detector CTs. The resolution is astronomical.
Unbelievable clarity.
But we have to address the conflicting data in the literature, because not everyone agreed CTA was the holy grail.
Right, there are skeptics.
The text specifically calls out a 2009 study by Goodwin and colleagues that reported a shocking 29% sensitivity for 16-slice and only 54% for 64-slice CTA.
Yeah, the authors of our textbook chapter are highly critical of the Goodwin study, and rightly so.
Why is that?
Well, when you have dozens of multi-institutional trials showing 98 to 100% sensitivity, an outlier showing 29% points heavily to methodological flaws.
Like what kind of flaws?
Primarily a lack of strict quality control in the scanning protocols or the interpretation algorithms. More recent, robust data from the Memphis group demonstrated that modern 64-slice CTA is so accurate it can essentially replace DSA entirely.
Wow.
They noted that the minuscule fraction of false negatives were exclusively grade injuries that carried virtually no clinical significance.
So the consensus is clearly solidified.
Oh, absolutely.
The 2020 Practice Management Guidelines from the Eastern Association for the Surgery of Trauma now officially recommends CTA as the primary screening modality for patients with high-risk cervical spine injuries and conditionally recommend it for low-risk C-spine patients.
Yep, it's a standard.
So let's bring it back to the clinical workflow. The trauma patient gets the 64-slice pan scan. The radiologist spots a distinct intimal flap in the V3 segment of the vertebral artery.
Okay.
They pick up the phone to call the trauma surgeon. They don't just say the artery is torn. They have to communicate the exact architectural severity of the lesion using a highly specific, standardized language.
Because standardization is the bedrock of critical care.
Right.
The Denver group recognized early on that a BCVI is not a monolithic diagnosis. A microscopic scrape on the endothelium has a profoundly different natural history, healing potential, and stroke risk compared to a completely severed vessel.
Makes sense.
To stratify this risk and guide treatment, they developed a 5-tier grading scale based purely on the angiographic appearance of the lesion.
This grading scale is brilliant, but it can be a bit abstract.
Sure.
Let's break it down using a structural engineering analogy.
Let's do it.
Imagine assessing a vital concrete bridge after a massive earthquake. Grade of first is essentially a crack in the pavement.
Okay.
Angiographically, we're looking at a minor irregularity of the vessel wall, or a small dissection or intramural hematoma that causes less than 25% luminal stenosis. The bridge is structurally sound, traffic is flowing, but the surface is roughed up.
From a clinical standpoint, the stroke risk for an untreated grade I lesion is relatively low, but certainly not negligible.
What are the numbers?
It's 3% for carotid injuries and 6% for vertebrals. What is paramount for the trauma surgeon to know is the healing trajectory.
Right.
Over 50% of these grade I injuries will completely heal on their own, the endothelium repaving itself, which eventually allows us to safely discontinue antithrombotic medications.
Moving up, grade 2 is where the structural integrity of the bridge is actively compromised. A main support beam is bending. Radiographically, this is visualized as a distinct intraluminal thrombus, a raised intimal flap, or a dissection that causes 25% or more narrowing of the true lumen.
This is where the risk profile escalates aggressively.
Yeah.
If left untreated, the stroke rate jumps to 14% for CAIs and a staggering 38% for VAIs.
38%.
Furthermore, the biological fate of a grade 2 lesion is grim. Unlike the minor cracks of grade part, less than 10% of grade 2 lesions will ever completely heal.
Which means long-term therapy.
Exactly. The patient is likely facing long-term or lifelong stroke prevention therapy.
Grade 3 is the bridge bulging outward, threatening to collapse into the river. This is the pseudoaneurysm.
Ah, the grade 3.
The high-pressure arterial blood has punched right through the inner layers of the vessel wall and is ballooning out the adventitia. The stroke rates here are severe, 26% for carotids and 27% for vertebrals.
Yeah.
But I want to pause here. Why is a pseudoaneurysm so highly associated with stroke? Is it just the risk of it bursting?
Rupture is a risk, but the real ischemic stroke risk comes from fluid dynamics.
Okay, explain that.
When blood enters the sac of a pseudoaneurysm, it loses its laminar flow. It swirls, it stagnates, and it creates a highly turbulent microenvironment.
And stagnant blood clots.
Right. Stagnant, turbulent blood rapidly clots. Those clots form inside the sac and then periodically break off, embolizing distally into the brain. It is basically an active clot factory attached to the side of a critical artery.
That is absolutely terrifying.
It is.
Grade the fourth is the bridge completely blocked by massive debris, complete vessel occlusion. The artery is choked off entirely. Traffic has stopped.
The worst case scenario for blood flow.
For carotid injuries, the stroke rate hits a massive 50%. For vertebrals, it's 28%.
And finally, grade V. The bridge has completely collapsed into the river below.
Vessel transection.
A complete free rupture with a contrast dye actively extravasating out of the vessel and into the surrounding soft tissues on the scan. If the patient survives the initial exsanguination, the stroke or neurological death rate is 100%. For both the carotids and vertebrals.
Now, in clinical practice, not every image is a pristine textbook example. The Portland group brought forward a highly nuanced issue, the indeterminate dilemma.
Ah, yes, the gray area.
They found that many scans showed questionable linear opacities, minor stretch injuries, or localized vasospasm that didn't fit neatly into the Denver eye through V-boxes. They tracked 59 of these indeterminate, maybe lesions.
And the follow-up data on those indeterminate lesions dictates our clinical posture.
What did they find?
39% of them resolved entirely, likely proven they were just transient vasospasms. 36% remained indeterminate.
Okay.
But a critical 25% progressed and blossomed into true classic BCVIs.
1 in 4.
Exactly. And statistically, there was absolutely no difference in the rate of cerebrovascular accidents or transient ischemic attacks between the indeterminate group and the true BCVI group.
So the takeaway for the surgical team is absolute vigilance.
You cannot dismiss a maybe on a CTA.
Right. You have to treat the indeterminate lesions just as aggressively as the definites, because 1 in 4 is going to declare itself as a stroke-causing lesion. And understanding the specific grade is what drives your entire follow-up protocol.
Correct. The grade dictates the timeline.
How so?
If you diagnose a patient with an isolated grady carotid injury, protocol dictates you bring them back for a repeat CTA in 7 to 10 days.
Why that time frame?
Because there is a greater than 50% chance that the intima has healed, meaning you can immediately stop their systemic blood thinners and reduce their bleeding risk.
Makes sense.
But if you diagnose a grade 3 pseudoaneurysm or a grade 2 severely stenotic flap, the chance of complete resolution at 7 days is practically zero.
So don't bother scanning.
Right. Re-imaging them that early is a waste of hospital resources and an unnecessary contrast load for their kidneys. For those high-grade lesions, you plan a repeat scan for 3 to 6 months out because you know they're locked into long-term medical management.
Which brings us to the most agonizing, high-stakes tightrope walk in all of critical care medicine.
The treatment.
We've found the tear, we've graded it, now we have to treat it. The pathophysiology dictates that to prevent the stroke, you absolutely must stop the platelet cascade.
You have to thin the blood.
You must thin the patient's blood immediately.
But we have to look at the macro-level reality of the polytrauma patient. They didn't just walk into a clinic with a torn vessel.
Right.
They were pulled from the wreckage of an automobile. They might have a traumatic brain injury with an actively expanding subdural hematoma. They might have a grade 3 splenic laceration or a shattered pelvis with a massive retroperitoneal hematoma.
Exactly. If I am the attending trauma surgeon and my patient has a bleed in their brain, the very idea of starting a continuous intravenous drip of heparin sounds like the definition of malpractice.
It sounds crazy.
How do we justify aggressively thinning the blood of a patient who is already bleeding?
It requires immense data-driven courage and a profound understanding of pharmacological kinetics.
Okay, walk us through it.
The core mandate is that the risk of the ischemic stroke from the BCVI almost always outweighs the risk of worsening the existing hemorrhage, provided you use the correct protocols.
Right.
Let's examine the heparin protocol specifically, because the authors detail a critical trauma-specific modification that makes this tightrope walk possible.
Traditionally, when you start a patient on a heparin drip for something like deep vein thrombosis, you give a massive upfront bolus, a loading dose, to rapidly spike their blood concentration to a therapeutic level, and then you run the continuous drip to maintain it.
But in a multi-system trauma patient, that massive upfront bolus caused catastrophic, unacceptable rates of hemorrhagic complication.
I can imagine.
The systemic shock of that bolus caused solid organ injuries to rebleed and intracranial hemorrhages to expand fatally.
Right.
So the protocol was heavily refined for trauma. Today, systemic anticoagulation for BCVI is initiated using a continuous infusion of heparin at 15 units per kilogram per hour, strictly without a loading dose. No bolus. You slowly and meticulously titrate the drip to achieve a partial thromboplastin time, or PTT, of 40 to 50 seconds.
It is a brilliantly calculated microscopic gamble.
It really is.
By skipping the bolus, you avoid the sudden violent spike in blood thinning. It takes a few hours longer to reach a therapeutic PTT, but you achieve a gentle clot stabilization.
Exactly.
And the safety net with heparin is its extremely short half-life. If the neurosurgeon calls down and says the patient's brain bleed is worsening, you shut off the drip, and if necessary, you can reverse it almost instantaneously with protamine sulfate or fresh frozen plasma.
The safety data on this modified no-bolus protocol is just phenomenal. The authors report that less than 1% of their treated patients experienced a bleeding complication severe enough to necessitate a blood transfusion.
But safety's only half the equation. Does it actually prevent the stroke?
The numbers from the literature are staggering.
Yeah, let's hear them.
The Memphis group demonstrated that initiating antithrombotic therapy for carotid artery injuries dropped the stroke rate from an apocalyptic 64% down to just 6.8%.
Wow.
For vertebral injuries, it plummeted from 54% to 2.6%. And the authors of our chapter. Their institutional data showed an overall stroke rate of an almost unbelievable 0.3% in treated patients, compared to 21% in those who were untreated.
That is an absolute risk reduction that you rarely see in any field of medicine.
Zero is rare.
But the anxiety surrounding when to start the drip in patients with severe concomitant injuries remains the primary point of friction in the ICU.
Oh, the timing is a massive debate.
We have highly compelling retrospective data to guide us here. The Memphis group reviewed 119 patients who had a confirmed BCVI, but also had a concurrent TBI, solid organ injury, or both. They initiated antithrombotic therapy immediately upon diagnosis in all of them. The result: they observed no differences in the radiographic progression of the brain injuries and no increased need for delayed operative interventions, like a splenectomy, for the solid organ injuries.
And the Houston group corroborated this in a massive review of 323 patients.
But I want to push back on the methodology of these studies for a second.
Go for it.
These are retrospective observational databases. They aren't randomized controlled trials. Isn't it highly likely that the patients who received early heparin were carefully selected by the surgeons because their head CTs already looked incredibly stable?
Absolutely.
That is textbook selection bias.
You are identifying the exact methodological flaw that limits the current literature. It is undeniable selection bias.
Right.
The surgeon at the bedside is making a clinical judgment call that a particular TBI is stable enough to tolerate heparin. We desperately need prospective, randomized controlled trials to definitively establish the safety parameters of early antithrombotics in severe, unselected polytrauma.
But we don't have that yet.
No. So until that data exists, the clinical consensus must rely on the best available retrospective evidence. That consensus is, once physiological stability is achieved and the patient's coagulation status is normalized from the initial shock of trauma, you initiate therapy.
And what about the choice of agent? It's not just heparin.
Oh, the great pharmacology debate.
The debate between using anticoagulants like intravenous heparin or oral warfarin versus antiplatelet agents like aspirin or clopidogrel is one of the most hotly contested topics in the chapter.
It is a fascinating debate. Historically, for general non-traumatic cerebrovascular disease, the landmark study by Chimowitz initially suggested that warfarin was vastly superior to aspirin for treating vertebral occlusive disease.
Okay.
But medicine is iterative. A subsequent, much more robust prospective double-blind trial by that exact same group, focusing on symptomatic intracranial atherosclerotic stenosis, completely overturned their previous finding. Yeah. They proved that aspirin was actually the therapy of choice. It offered equivalent stroke prevention efficacy, but resulted in significantly fewer catastrophic hemorrhagic complications compared to warfarin.
And because aspirin is essentially a universal, cheap, once-daily pill of 325 milligrams that doesn't require obsessive, every 6-hour PTT blood draws, it gained immense favor in trauma ICUs for treating BCVI.
It's just easier.
But the chapter cites a very recent study by Hannah and colleagues that throws a massive wrench into the aspirin is best consensus.
Yes, the Hannah study is a critical piece of recent literature. They utilized the nationwide readmission database, performing a retrospective analysis.
Okay.
To account for the selection bias we just discussed, they used one-to-one propensity score matching.
Which is a statistical technique designed to balance the covariates so the two groups look as identical as possible.
Exactly. They compared 185 patients discharged on antiplatelets to 185 patients discharged on anticoagulants. Crucially, these were predominantly patients with high-grade BCVIs.
And what did the propensity match data show?
It showed a stark difference in long-term outcomes. The patients managed with anticoagulant medications had a significantly lower rate of hospital readmission for stroke.
By how much?
1.8% versus 5.7% for the aspirin group. Even more compelling, the anticoagulant group had a dramatically lower 6-month mortality rate, 1.3% versus 4.9%.
Wow. So for the really severe injuries, the true structural flaps and pseudoaneurysms, the heavier artillery of heparin and warfarin might actually be saving significantly more lives in the long run.
It strongly suggests that for grade 2 through 4 lesions, simple platelet inhibition with aspirin might not be sufficient to hold back the thrombotic tide.
Right.
But again, propensity score matching is only as good as the variables you can measure. It cannot account for unmeasured clinical confounders that a database simply doesn't capture.
That's true.
Furthermore, we are operating in an evidence void regarding the newer direct oral anticoagulants.
The DOACs.
Right, like factor A's inhibitors or direct thrombin inhibitors. We use them ubiquitously for atrial fibrillation, but we have virtually zero high-quality data on their efficacy or safety for traumatic BCVI. That is the next massive frontier for surgical research.
Speaking of frontiers, we have to talk about thrombolistography, or TEG.
Oh, TEG is game-changing.
When I read this section, it felt like reading science fiction. Standard coagulation panels like PT, INR, and PTT are just static numbers. They tell you how many seconds it takes for a clot to form in a test tube.
Right.
But TEG is viscoelastic testing. It measures the physical, mechanical properties of the blood clot in real time.
The mechanics of TEG are brilliant. You place a sample of the patient's whole blood into a small heated cup that gently oscillates. A pin is suspended into the blood.
Okay.
As the fibrin cross-links and the clot begins to form, it physically binds the cup to the pin, creating mechanical resistance. The machine plots that resistance on a graph.
So you can actually see it happening.
Yes. It tells us exactly how fast the clot initiates, the kinetic rate of its growth, its absolute maximum physical strength, and how quickly it breaks down. It provides a dynamic, individualized physiological fingerprint of the patient's coagulation status.
And the data on TEG in BCVI patients is mind-blowing.
It really is.
A preliminary study highlighted in the text demonstrated that patients who eventually suffer a BCVI-related stroke are actively, demonstrably hypercoagulable compared to BCVI patients who do not stroke.
Yeah, their blood is just acting differently.
The machine literally shows their blood acting aggressively. The stroke patients form clots faster, which is evidenced by a larger TEG alpha angle, 77.5 degrees versus 74.6 degrees.
Right.
And they form physically stronger, more resilient clots, indicated by a maximum amplitude, or MA, of 113 millimeters versus 121.
When you look at the odds ratios derived from that data, the clinical implications are profound.
Break it down for us.
If a trauma patient's TEG angle is greater than 77.3 degrees, they are nearly 3 times more likely to suffer a stroke.
Wow.
If their maximum amplitude exceeds 63 millimeters, they are over 4 times more likely to stroke. This completely reframes how we view the pathophysiology.
Because it's not just the tear anymore.
Exactly. The intimal tear is merely the nidus, the spark, but it is the patient's systemic hypercoagulable response to the overall polytrauma that acts as the gasoline, driving the massive thrombus formation.
Which means in the very near future, trauma surgeons won't just use TEG to figure out what blood products to give a bleeding patient. They will use it to heavily personalize and aggressively up-titrate systemic blood thinners for specific patients whose TEG proves they are highly prone to throwing a stroke-causing clot.
Exactly. We are moving toward precision, targeted biochemical therapy based on a patient's unique real-time physiological response.
Now, I know what many technically minded surgeons listening might be thinking.
I can guess.
We've spent all this time debating the pharmacology of aspirin versus heparin. But we are surgeons.
We want to fix it.
If there's a torn vessel, why don't we just operate? Why don't we expose the vessel, resect the damaged segment, and perform a primary anastomosis or interpose a vein graft?
Right.
Or, failing an open approach, why not deploy an endovascular stent to plaster the torn intima flat against the arterial wall.
It is the defining instinct of this surgical personality to want to physically fix the anatomical defect.
Exact.
But the brutal reality of blunt cerebrovascular injury is that 99% of these lesions are fundamentally anatomically inaccessible to an open surgical approach.
99%.
Yes. We have to return to the anatomical mechanisms we discussed in the beginning. These injuries occur almost exclusively at the rigid bony fulcrums.
Right, the skull base.
The internal carotid artery stretches and tears high up in the carotid canal, literally at the base of the skull. The vertebral artery shears deep inside the bony transverse foramina of the cervical vertebrae.
So you just can't get to them.
You cannot put a scalpel, a retractor, or a clamp into those spaces without completely dismantling the skull base or the cervical spine, which would cause catastrophic, fatal damage to the surrounding cranial nerves and venous sinuses.
Wow.
Operative management is essentially a historical myth, strictly reserved for the extraordinarily rare 1% of injuries that happen low enough in the accessible neck to allow for safe proximal and distal vascular control.
Okay, so open surgery is completely off the table. But what about endovascular stents? We use them ubiquitously in cardiology for acute myocardial infarctions.
All the time.
We thread them up into the brain for elective aneurysm coiling. Logically, it sounds like the perfect, elegant solution for BCVI.
It does.
Thread a microcatheter up from the femoral artery, deploy a tiny rigid metal mesh stent directly over the intimal tear. The stent acts as a scaffold. It smooths out the laminar blood flow. It physically traps any existing friable thrombus against the vessel wall so it cannot embolize into the brain. And if there is a grade 3 pseudoaneurysm, the mesh diverts the turbulent flow away from the sac, preventing expansion or rupture. On paper, it sounds utterly flawless.
On paper, it is flawless. And at the turn of the century, roughly 20 years ago, there was an absolute explosion of enthusiasm within the interventional community for stenting these traumatic injuries.
People were excited.
It felt like the ultimate technological fix. But the harsh empirical data that emerged over the next decade told a vastly different, deeply humbling story.
The data showed it was a disaster. Why did the stents fail so spectacularly?
We learned a brutal lesson in vascular biology. An acutely injured, massively inflamed, traumatized vessel behaves completely differently than a chronically diseased, atherosclerotic vessel.
How so?
In a trauma patient, the endothelium is highly reactive. Tissue factor is everywhere. When you introduce a rigid, foreign metal object, the stent into that freshly torn, highly hypercoagulable microenvironment, it acts as a massive catalyst. The metal provokes an overwhelming thrombotic response. One pivotal study cited in the text demonstrated that placing a stent for BCVI carried a 17% overall complication rate and an utterly catastrophic 45% occlusion rate.
I want to make sure I'm interpreting that correctly.
Go ahead.
Almost half the time, an interventionalist deployed a stent with the specific intention of keeping the vessel open. The metal stent itself caused the vessel to aggressively clot off entirely.
Exactly. The intended cure became the primary driver of the disease. The stent induced the exact pathology it was designed to prevent.
That's devastating.
Furthermore, deploying a stent does not magically absolve you from using blood thinners. In fact, patients with bare metal or drug-eluting stents require aggressive dual antiplatelet therapy, usually aspirin and clopidogrel, for months to keep the metal itself from thrombosing.
Right.
So you are right back to facing severe bleeding risks in your polytrauma patient, but now you have the added risks of an invasive catheterization, significantly increased hospital costs, and data proving it offers zero benefit over medical management alone.
So despite all this incredible modern technology, advanced robotics, endovascular microcatheters, high-resolution imaging, the ultimate, most advanced, most sophisticated fix we have for this highly lethal injury is basically just aspirin, heparin, and giving the body time.
That is the profound, beautiful irony of this specific pathology.
Yeah.
Sometimes the absolute zenith of advanced surgical decision-making is knowing exactly when not to deploy hardware.
Doing less is more.
The human body is miraculously adept at healing its own endothelial linings. If we simply use basic biochemistry to modulate the platelet cascade, preventing them from overreacting and forming a deadly occlusive clot, the native endothelium will organically repair the intimal tear over time.
And the guidelines reflect this now, right?
The current medical guidelines reflect this hard-won humility. The 2020 East guidelines explicitly strongly recommend against the routine use of endovascular stents for grade 2 or grade 3 injuries.
Stents have been entirely relegated to a salvage maneuver. You only deploy them for a patient who is actively progressively symptomatic from a severe flow-limiting luminal blockage that is failing medical therapy, or for a traumatic arteriovenous fistula.
Or for a massively expanding pseudoaneurysm that is imminently threatening to rupture, usually defined as rapidly growing larger than 1.5 centimeters.
Right.
Or, in the most dire scenarios, endovascular embolization, deliberately deploying coils to intentionally plug the vessel, can be used as a desperate life-saving maneuver to stop the exsanguination of a grade V transection.
And the most recent data strongly validates this conservative, medically driven approach.
It does.
A comprehensive review highlighted that while stent utilization for BCVI dropped precipitously from 34% of patients in 2011 down to just 9% in 2016, the overall stroke rates did not change at all. Medical management with antithrombotics is definitively the gold standard of care. Taking a step back from the microscopic interactions of subendothelial collagen, the pharmacology of heparin, and the failures of metal stents, what does all of this mean for the big picture of trauma and critical care?
The overarching narrative of this textbook chapter is one of monumental collective scientific achievement.
Yeah, it's a huge win.
It is a testament to 30 years of relentless, methodical data collection, fierce multi-institutional collaboration, and meticulous protocol refinement. The trauma and critical care communities took an injury that once permanently disabled or outright killed almost half of its victims, and through sheer scientific rigor, engineered it into a highly manageable, highly survivable condition.
Incredible.
Through the implementation of the Denver screening criteria, the adaptation of the radiologist's eye to multi-detector CTA, and the courageous optimization of antithrombotic protocols in actively bleeding patients, the stroke rates associated with BCVI plummeted from roughly 37% in the 1980s down to between 1% and 5% today.
And the overall mortality dropped from a grim 24% down to less than 5%.
Unbelievable progress.
As you know from managing these polytraumas in the Bay, that is not just a statistical improvement on a spreadsheet. Those are thousands of lives saved. Those are thousands of patients who are walking out of neurorehabilitation centers instead of dying in the intensive care unit.
Yeah, real people.
It fundamentally highlights the vital importance of respecting the silent period. The recognition that a perfectly normal neurological exam in the trauma bay does not mean the patient is safe. We have learned to aggressively hunt the danger while it is still invisible.
But diving this deeply into the material also leaves us with a profound, almost philosophical, physiological paradox to consider as we look to the future of trauma care.
Which is what?
Blood clotting, the rapid, violent aggregation of platelets upon exposure to subendothelial collagen, is a result of millions of years of evolutionary brilliance. It is the exact, finely tuned mechanism designed to keep primitive humans from bleeding to death from a predator's bite, a spear wound, or a hunting accident. It is designed to save our lives.
Yeah.
Yet, in the era of modern high-speed kinetic trauma, in the fractions of a second during a 60-mile-per-hour motor vehicle deceleration, that exact same evolutionary survival mechanism is precisely what builds the clot that embolizes and kills the brain.
It is the human body literally destroying itself in a blind attempt to save itself.
Exactly.
And that leaves me with a final provocative thought for everyone managing these complex patients. As our imaging technology gets even more astronomically advanced, as we inevitably move beyond 64-slice CTs to microscopic, hyper-resolution molecular-level imaging, will we eventually discover that practically everyone who walks away from a roller coaster ride, a minor bumper car collision, or a hard tackle on a Friday night football field has microscopic intimal tears in their vertebral arteries?
It's a very real possibility.
Where exactly is the line between life-saving, proactive trauma screening and the over-medicalization of the human body's natural daily wear and tear? When the silent clock starts ticking, how closely should we really be listening?
A great question to end on.
Thank you for joining us on this deep dive. Stay curious, trust the data, and we will see you next time.